This is the oldest known case of metastatizing prostate carcinoma, more than 2,000 years ago, found in Russia. But now, today, after 2,000 years, we still have problems with the bone metastasis. Because if we think that the first cancers for male and female are prostate and breast, we know that they are both typically osteotropic cancer. In other words, they give bone metastasis in 60 to 70% of cases. And we know that 90% of cancer-related deaths in these cases are due to metastasis. So this is a big problem for our routine life if we deal with cancer. Then we have to ask ourselves how good are current imaging tools for detecting the presence, the volume, the viability, and the response of metastatic bone disease. And if our tools, what we have in our hands, are good for promoting precision oncology, which, in simple words, is the opportunity to give the right treatment to the right patient at the right time and for the right duration. Imaging usually reflects interactions between tumor and bone matrix. We know that tumor cells mostly promote secretion of DKK1, which alters the OPG rank ratio, activating osteoclastic activity and giving osteolytic metastasis. But there are cancers like prostate cancer and some breast cancers who give also osteoblastic metastasis because they promote also an activation of osteoblast. And we can really depict, for example, with CT, the beautifully osteoblastic and osteolytic activity. But there are also other kinds of imaging under the big umbrella of next generation imaging, for example, PET, which reflects metabolism, and the diffusion-weighted imaging, which reflects cellularity, which explains relations between tumor cells, the bone marrow, which is visualized especially with MRI, and the matrix. And this is an example of a published paper which has been mentioned today already. And there are cases in patients with multiple myeloma where both, on the left, both FDG PET and whole body diffusion MRI are positive. So more or less, they obviously look at different things. PET is looking at glucose metabolism, whole body MRI is looking at cellularity, but they display similar appearance. So the area of high metabolism in some cases corresponds to the area of high cellularity. But there are cases in this paper where the PET is negative, while whole body MRI is positive. And it has been found and documented in this paper that those patients with negative PET and positive whole body MRI had a deficit of exokinase 2, which was affecting the glucose metabolism. Whereas whole body MRI was positive. Why? Because it is really a specific marker. It just looks cellularity, and if there is a cellular cancer, then it should be Brighton diffusion-weighted images. But after this brief introduction, let's go to real life. It may happen that you have a patient that comes, a prostate cancer patient that comes at your institution asking for surgery. This patient came to us, PSA 29, digital rectal examination positive, and a Gleason 5+4, so really high-risk patient. But he had systemic staging at outside institution, which was performed according to guidelines. So CT abdomen and pelvis, which was negative, reported as negative, and bone scintigraphy negative. So in theory, it could be also eligible for surgery. But our urologist was skeptical, because we all know that out of this patient, not more than 15% of them can undergo surgery. So he came to me and asked, Giuseppe, can we do more for this patient? And then I said, of course we can do more for our patient. So let's do whole body MRI. And if you look carefully at the guidelines, European guidelines 2017, it is said that at least bone scan should be performed, but it has been recognized that MRI is superior to calling PET and bone scintigraphy for detecting bone lesion. And it is mentioned that this beautiful meta-analysis showing that the sensitivity per lesion of bone scintigraphy is 78%, while sensitivity of whole body MRI is 97%. So we did whole body MRI in this patient. And as you can see, it immediately appears that there are bright areas on whole body MRI. And if we look closely, there were pathologic lymph nodes in the pelvis, but also outside the pelvis, therefore metastasis. And what is interesting, there was a metastasis in the left rib. So this patient, I strongly believe that in this patient, whole body MRI promoted precision oncology because there was a big change in staging, but what was important, there were metastases, which determined a big impact in patient management because we went from a curative surgery to palliative hormone therapy plus radiation in the sites affected by metastases. So we had, thanks to MRI, we had the opportunity to give the right treatment to the right patient at the right time and for the right duration. Similar experience with a different cancer. A young patient, 33 years old, was operated for breast cancer in 2007. She stayed very well for 6 years, but then she came to us in 2013 for a recurrence, a local recurrence on the right breast, but sadly, a recurrence also in a left axillary node. So this patient was not anymore locally advanced breast cancer, she was histologically confirmed metastatic advanced breast cancer. So what should we do? Again, we look at guidelines. We have to stage carefully our patient, and they, with level of evidence 1, grade recommendation A, they suggest CT, but obviously they say, with level of evidence 2, PET-CT if available. And of course, PET-CT was available for our young patient, and we did PET-CT, which revealed nothing more that we knew already. PET-CT revealed a pathologic lymph node in the left axilla. But we tried to do more for our patient, and we did, after 10 days, whole body MRI, which confirmed the pathological lymph node on the left axilla, but showed subcentimetric metastasis in the liver, and what was interesting, 2 small lesions in the right sacrum and the left iliac bone. If we enlarge the image, we see that there was a very small metastasis in the left iliac bone, which was impossible to see with PET. And this was important again to promote precision oncology because we knew that the patient had metastasis in the liver, in the bone, so we started a proper chemotherapy, and after the first control, we had a complete response, and the patient stayed well for 12 consecutive whole body MRI controls. Probably the chemotherapy worked very well because the volume of the disease was very small when we captured it with MRI. And I'm not surprised because, again, citing a meta-analysis, including the majority of breast cancer, that the reported sensitivity for PET is 87%, for conventional MRI is 90%. In the previous meta-analysis we have seen with addition diffusion, it can be more than 90%, and probably there's a small difference between PET and MRI. It is evident in cases like this where the lesions are very, very small, like this patient. A few words about response. We have to say, sadly, that current imaging tools are limited. Because we know that RECIST is not applicable in metastasis. Yes, after 2009 we can measure bone metastasis only if they have spread into soft tissues more than 1 centimeter, which usually do not see in real life. And we have, with current imaging tools, 3 big problems. We are not really able to detect early the response. We are not sometimes able to detect the progressive disease, and we are often unable to capture heterogeneity of the response. We will see example of this. If we use bone scintigraphy, we know very well that bone scintigraphy does not directly evaluate the malignant bone disease, but only the reactive osteoblastic uptake. So, in real life, it means that if we see a progressive disease, a PD on scintigraphy, it has to be confirmed on a subsequent scan. So, it may cause very big delays in detecting PD. CT, we know that it shows beautifully osteoblastic and osteolytic activity. But this is not the entire picture. There are also criteria relying on this, the MD Anderson criteria. When we see a complete response, we may see a complete fill-in osteosclerotic evolution of a metastasis could be considered a complete response, but when there are other signs of response in other organs. So there are problems what to do in patients who only have bone disease, which often happens in prostate cancer and breast cancer. Second problem, we cannot apply this criteria when patient is receiving anti-osteoclastic therapy, bisphosphonates, denosumab, that our patient very often receive. And last but not least, it is often difficult, also in experienced hands, to distinguish between osteosclerotic progression and response. So practically, we see that sometimes PD occurs on CT without using it. And this is not a personal opinion. This is real experience, and it has been documented. The group of Professor Padani published a paper recently comparing CT of chest, abdomen, and pelvis and whole body MRI. They took 210 pairs, exams performed at the same, more or less same timing, within 14 days, in 100 patients, all metastatic breast cancer. They observed that out of these episodes, they observed that in 46 cases there was a therapeutic change due to PD detected at imaging. Out of these 46, in 16 cases, the PD was only seen by whole body MRI. In other words, in 35% of cases, whole body MRI detected progressive disease earlier than CT, which is quite important. We repeated a similar experience by comparing CT, chest, abdomen, and pelvis with a comparison exam, which was in our case CT or PET, because we do also PET in our institution. And we saw that out of 58 pairs, in 28 cases, there was a therapeutic change due to PD at imaging. Out of these 28, in 14 cases, the PD, so in 50% of cases, MRI detected PD earlier than CT or PET, which confirms previous experience. And this is an example, typical example. We have a patient, 69 years old, breast cancer, rising tumor markers during hormone treatment. Then he starts the nightmare of the oncologist, and he starts asking exams. He asked for this case CT, chest, abdomen, and pelvis, which was reported as negative. Then he was not satisfied. He asked whole body MRI, and we saw very small bone metastasis here in these axial images. You see at the lumbar level, the white arrow, and the black arrow, some other metastasis on the spine. So this is a typical, something that we see every single day. PET-CT for response. There are criteria for PET-CT for response, the PET criteria. However, PET-CT is beautiful for detection. It may suffer from osteoblastic for flare in response assessment. What we believe works pretty well for response assessment is MRI. Also, morphological conventional MRI works very well because we have criteria. Because MRI relies mainly on bone marrow assessment. So we have a clear pattern of complete response, like in this case. You see on the left a metastasis, and on the right the return of fat, which means complete response. On the bottom row, you see on the left a partial response. On the left, the metastasis. On the right, a fatty halo signs. It means that the metastasis is recovering with fat coming from the edges to the center of the lesion. And there are also criteria for progression. You see at the top row, from left to right, you have the appearance of metastasis and fat disappears. At the bottom, you have also criteria of early progression with the appearance on T2 facade of a cellular halo sign, which are tumor cells that grow at the edges of metastasis, which are an early sign of progression. So, now that we discussed typical signs of response assessment with MRI, we are able to understand probably what is happening to this patient. Exam baseline and after therapy with paclitaxel plus GCSF. What happens? This patient has metastasis in the dorsal spine and the lumbar spine. So what is your judgment? Is she progressing? Is she stable or response to therapy? From these images, I think we would report as stable, more or less the same. But if you add diffusion-weighted imaging, you understand that there is a response to therapy. And in particular, if you enlarge the image here, and if you measure ADC, you see on the ADC map that the metastasis was dark at the beginning with ADC value of 700, 800. After therapy, 1600, and extremely bright. This is a response to therapy, which is captured by functional imaging, but on conventional morphological MRI, there is still a residual scar tissue that you will see for months before it will recover with fat. Another case, morphological MRI before and after therapy with capecitabine and vinorelbine. A 45-year-old lady with breast cancer. After 4 years, she developed bone metastasis. She started the chemotherapy, and then we have to check if she's doing well or not. If we just look T1, it could be confusing because what you see on the right before and after, it could look more, it's more hypointense. So are we ready to write progression? Or we would like to stay more conservative and saying stable? Actually, it's a response because if you look diffusion-weighted imaging, you see that the patient clearly has responded and the diffusion water molecule is clearly less impeded with diffusion-weighted imaging. But if we would like to look more in depth, to analyze more in depth our patient, we need to use quantitative imaging. There is this software by Siemens, Total Tumor Load, which allows us to display the ADC values on the diffusion-weighted images. So, and we can color code the colors to create a sort of habitat imaging, because we can give red colors to tumors in the active range with the ADC value of the active range, yellow colors in tumor that is dying, and the green color in tumor which are dead with ADC above a threshold of 1500. So if we look at our patient, we see that clearly there has been a response from red to red and green. But there are still areas who did not respond to therapy. There are clones who are resistant to therapy. And if we run a more in-depth analysis with first-order statistics, which are histograms, you can see that before therapy, the majority of voxels were in the red area, the active disease. After therapy, there was clearly a shift towards response, towards yellow and green values, but still a little bulge here of clones who are resistant to therapy, which were still in red. And when you see this pattern, you can predict that on a subsequent scan, the patient will have a relapse. And this is exactly what happened to our patient. So again, on the left, you see 94% of the volume was active disease. After 3 cycles of therapy, was a mixed response with some response, but still aggressive clones, which are displayed especially. We know where are the aggressive clones with this kind of imaging. And after 3 cycles, again, probably this clone expanded and covered the remaining volume. And as you can see here from histograms, 10.1 in the red, 10.2 the little bulge, 10.3, which is the yellow, the orange, again in the active range. And I'm not surprised, because we all know that cancer evolve in time and space like a Darwinian process. And there are various factors that drive selection, and one major factor is therapy itself, which selects aggressive clones that develop and eventually spread metastasis. And if you stick a needle on a metastasis, you can keep track from its origin, and from building a phylogenetic tree, you can understand from mutation where the metastasis came from. You can build a phylogenetic tree which reminds you exactly what was the draft of Darwin, I think, the very famous tree of life. And you can display with this quantitative imaging the distribution of aggressive clones over the entire body. And this is important because we have the unique opportunity now to stick our needle only in the aggressive part. As in this real life experience, our patient she stayed very well. She underwent chemotherapy, response after some point rising of tumor markers. You see in these pelvic bones, all lesions were still bright on NDC, but there was just one lesion here, bright on diffusion, dark on NDC, which was likely responsible for the increase of tumor markers. And that lesion was, in that lesion, I stick the needle to understand what kind of cancer was. And it was also demonstrated in papers that you can really find the mutation, as they did the authors in this paper, a patient with breast cancer, the stick needle, with prostate cancer, sorry. There was a metastatic disease on the pelvic bones, the stick needle on the left iliac bone. They found a BRCA2 mutation. They gave a PARP inhibitor. He was cured for 9 months. He had a relapse after 9 months. On the right iliac bone, there was a needle inside this right iliac bone, but the BRCA2 mutation was reversed. So, trying to summarize what we said up to now, until now. This is what we are, in theory, able to do in our patients. We have to combine, we have the opportunity to combine clinical data with quantitative data coming from MRI under the big umbrella of radiomics, which are first-order statistics, second-order that we have already with our softwares, texture analysis and transform analysis up to third-order statistics. We have it. We can have genomics because we have an opportunity with MRI to stick needles in the aggressive areas and to understand if there are mutations in that areas. And we can combine all this information in a new field called radiogenomics with the hope of improving risk stratification, early diagnosis, treatment selection, and so on. Everything through a very integrative analysis of all this information, maybe using artificial intelligence because it is really a large amount of data in order to achieve our first aim, which is precision oncology. It may look very complex, but the revolution, it is already happening because we strongly believe that whole body MRI will soon replace current imaging tools for bone assessment. And it is already happening if you just look at guidelines. Now whole body MRI is in the guidelines of multiple myeloma for staging. And in some cases also for follow-up oligosecretory multiple myeloma. It is mentioned in prostate cancer guidelines. It is mentioned whole body MRI as an alternative to PET-CT, SCT in Swiss and German guidelines for melanoma. It is in the NCCN guidelines for Li-Fraumeni syndrome. And there is a wide use in many oncological centers for metastatic breast cancer. The majority of the examples you have seen are from breast cancer. And for lymphoma, where it has comparable results to PET. And there's a great interest also in the use of whole body MRI for cancer screening. And there are guidelines already, because whole body MRI, someone is scared about whole body MRI like a complex technique. It's not complex. It has been standardized, and there are guidelines to overcome limitation of current imaging diagnostic methods. This is the proposition of MET-RADS guidelines, because guidelines established which is the protocol, how images should be processed, how images should be reported. And the guidelines were very well accepted. There was a paper under this guideline saying that this is a birth of a new standard that we should use. It makes our job simpler because soft tissue lesions, metastases on the soft tissues are divided in 7 body areas, and metastases in bones are divided in 7 regions. And for each region should be assigned a score rank 1 to 5, assessing the response independently for each region, just to capture heterogeneity of the response. And last comment, but not least, whole body MRI is very well accepted by patients, because someone think that the patient may not like. I felt from my personal experience that they love it, and then I formally evaluated it. And we recently published a paper. We included 135 patients, mostly breast and prostate cancer, which reflects our bigger population of cancer patients who underwent our standard protocol, which is more or less 40 minutes. Well, we discovered that more than 81% said that they had a high to very high level of satisfaction. 68% of them said that the whole body MRI was more acceptable than CT or PET-CT. Only 0.8, so below 1%, they thought whole body MRI was worse than CT or PET. So whole body MRI, I think it has many advantages. To conclude, precision oncology for metastatic imaging requires a detailed knowledge of the changing tumor biology at the whole organism level. And we believe that now bone scintigraphy and CT are really limited, because they have low sensitivity for detecting lesion and for detecting a progressive disease, which is important to tailor treatment to the single patient. And very often those two old techniques are not able to capture heterogeneity. Whole body MRI with diffusion adds function to morphology and offers the unique opportunity to have a highly sensitive technique for detecting lesion and progressive disease, as we have seen. And it is a purely quantitative technique, therefore it opens door to a radiomic pipeline and to radiogenomic analysis. And thanks to MET-RADS, it can capture very well heterogeneity of the response. So we believe that in the future, the integration of whole body MRI with PET under the big umbrella of next generation imaging, along with the integration of data, clinical, radiomic, and genomic data, is the key for the future. Thank you.